Thank you very much for the introduction. So these are my disclosures. So as mentioned by the previous speakers, it's a very exciting time to be managing and studying psoriasis. With the assimilation and collaboration, we're able to aggregate data from hundreds of thousands, even millions of patients together to help answer questions that previously remained enigmatic in psoriasis care. So I'd like to illustrate this with a case that I've been managing over the last 6 years, which has given us a new insight into the relationship between psoriasis and its comorbidities. So this was a 30-year-old lady who was aged 30 when I first met her. She had a 9-year history of psoriasis. As you can see, it was quite widespread. She had scalp and nail involvement, and it was really affecting her confidence and quality of life. So she was a single mother with 3 children, one of whom had learning disabilities. She smoked 10 cigarettes a day and drank 20 units of alcohol per week. She had a strong family history of psoriasis, diabetes, and heart disease through her father and her paternal grandfather. We started her on UVB phototherapy, and initially she had a very good response. However, 3 years later, she relapsed and was started on methotrexate, but this had to be stopped after 2 months since she developed deranged liver function tests. We then started her on apremilast, and although she had a good initial response, again, this had to be stopped after 5 months following a depressive episode. Then acutely, she was admitted to the accident and emergency department with left-sided weakness and was found to have changes in keeping with an ischemic stroke. She was started on secondary preventative medications, and as you can imagine, this had a tremendous impact on the life of a 36-year-old with dependence. It also affected her treatment. We wanted to start her on UVB phototherapy, and unfortunately she had problems with balance, so was unable to stand in the cabinet. It's a challenging case, but also some challenging questions. So when I last saw her in clinic, she asked me, is there a connection between psoriasis and cardiovascular disease? She also asked if my cardiovascular disease is well controlled with stroke medication, will that help my psoriasis? So I really wanted to share this with you guys today because this links well with research that we've done over the last few years at King's College London. And this was actually published last Wednesday in JAMA Cardiology, so feel free to take a scan of the QR code if you wish to look at the full paper. Of course, there is a connection between cardiovascular disease and psoriasis. There's up to a 4-fold increased risk of stroke and up to a 5-fold increased risk of myocardial infarction in severe psoriasis. And unsurprisingly, this translates to an increase in excess deaths in the psoriasis population. But the relationship between psoriasis and cardiovascular disease is incompletely understood. A very prominent hypothesis is that the characteristic cutaneous inflammation of psoriasis propels a systemic inflammatory response, which promotes the risk of cardiovascular disease. Evidence for this comes from both blood and within atherosclerotic plaques, where it's been demonstrated that there's overactivation of the IL-17/23 pathway, which plays an important role in psoriasis. There's also evidence from clinical trials that there can be improvements in subclinical imaging-based measures of coronary artery disease in individuals who take biologic treatments. Indeed, if it were shown that psoriasis could drive cardiovascular disease, this could potentially lower the threshold for the use of systemic and biologic agents to help simultaneously improve psoriasis, but also potentially reduce the risk of cardiovascular events. It's important to note that psoriasis and cardiovascular disease share multiple risk factors, including metabolic syndrome and its components, as well as smoking. And this really formed the basis for our study to firstly evaluate the bidirectional relationship between cardiovascular disease and psoriasis, and also the influence of key confounding factors. To address this, we use a powerful genetic technique called Mendelian randomization, which I'll refer to as MR. This uses genetic variants from genome-wide association studies. And if it can be shown that these genetic variants associate strongly with a trait called an exposure trait, but also with a second trait, an outcome trait, with a proportionate effect size, this can give strong evidence of potential causality between the exposure and the outcome. Since genetic variants are fixed and randomly assorted at conception, they're less prone to the confounding effects as well as effects of reverse causation that can frequently limit the inference of causality from conventional epidemiological approaches. So this is a perfect example of the use of big data. Of course, we're looking at tens or hundreds of genetic variants in 3.4 million patients. So answering our first question, do genetic predictors of psoriasis increase cardiovascular risk? We looked at 109 genome-wide significant variants from a recently published psoriasis genome-wide association study meta-analysis and looked at their effects on coronary artery disease and stroke meta-analyses respectively. So here I've summarized the results which show the inverse variance-weighted causal estimate, which is a summary of the causal effect, shown as an odds ratio with a 95% confidence intervals shown with the error bars. And we found no evidence that genetic predictors of psoriasis were associated with coronary artery disease or stroke. And just for comparison, I've shown the relative risk from a previously published observational study in a primary care cohort, just for comparison. So let's reverse the question. Do genetic predictors of cardiovascular disease increase the risk of psoriasis? For this, we took 241 genetic variants that associate with coronary artery disease and 47 for stroke. And we assessed their effects on psoriasis in the previously mentioned genome-wide study meta-analysis. So here we found a statistically significant risk-increasing association between genetic predictors of cardiovascular disease, so it's coronary artery disease and stroke, with psoriasis. Again, I've shown the previous results from that observational study that I mentioned. So the next question was to understand whether these effects were independent of one another. And to do this, we used multivariable MR, which enables the evaluation of the effect of an additional variable by inserting it as a variable in a multivariable regression model. We found that the coronary artery disease association with psoriasis and the stroke association with psoriasis were no longer significant when adjusting for the other cardiovascular trait, indicating that there's likely to be significant overlap and that a shared cardiovascular effect underlying coronary artery disease and stroke are likely to mediate this MR association. So now looking at confounding factors, again we use multivariable MR. We adjusted for a range of components of metabolic syndrome as well as smoking, both individually as well as collectively in a multivariable MR model. And when adjusting for these, we found that the association between genetic predictors of cardiovascular disease and psoriasis remains significant and even after adjustment, indicating that they're likely to be independent of confounders. So in summary, our data shows that genetic predictors of cardiovascular disease increase psoriasis risk. So this implies that the biology of cardiovascular disease influences the causal biology of psoriasis. I think the value of this research really lies in the translational pipeline. There's two ways. Firstly, in the identification of biomarkers, which can help with risk stratification to help identify individuals who are at high risk of developing cardiovascular disease early so that we can institute primary prevention. And secondly, of course, there are many steps between genetic variants from proteins to biological processes all the way through to health and disease. So identifying the molecular mechanisms, which is the next step in research, is to, this could potentially identify new drug targets that could ultimately help the improvement of the management of both psoriasis and cardiovascular disease. So reflecting on our case and this research, we show that genetics can be a powerful computational tool to help understand the relationship between psoriasis and its comorbidities. These data and findings such as these really raise the awareness for the association and the need for this awareness at both the patient level and the health professional level to help with screening for risk factors. It's also important for dermatologists to consider a more proactive, multidisciplinary approach to identifying and treating early atherosclerosis, particularly in high-risk patients with psoriasis. I'd like to thank my lab group as well as the collaborators for helping with putting the case together and my research. Thank you very much.